So my name is Sonya Noor. I am also a vascular surgeon from Buffalo, and I am presenting. Thank you to Endologics for sponsoring this session, the breakfast session, and I'm focusing specifically on disparities in EVAR when it comes to women. Um, when I was a fellow, which was a long time ago, and Dr. Harris was a very young attending, we that back then we talked about women having aneurysms as 10% or less, right? Like that's pretty standard. 10% or less is what women have. But I think as studies have come up and as we've looked into women actually having aneurysms, the numbers actually a little higher. And when they do have aneurysms, I'm going to highlight to you with studies, they actually do worse than men do. So women outcomes in aneurysms is actually significantly, you'll see multiple studies, worse than men do. So interestingly, Peter Burtis did this article in 2007. It was in the JDS in 2007. And he actually pointed out when he went back and reviewed 17,000 patients, 20% of aneurysms actually occur in women. So really the incidence isn't 10% or 12% like he thought. It's actually higher. And then there's two other things that I'm going to highlight that he found out that you will see in subsequent studies. And that is one is women tend to get their diagnosis older, which is an interesting problem because it isn't really an access problem. Are we really taking care of ourselves? Like, do we just, you know how it is? Is it just because they're getting diagnosed later because they're not taking care of the problem sooner? But they do tend to be older. And they have cardiovascular morbidity, probably because of age, but also because of smoking. And so, if you think about our screening right now for women specifically, we talk about family history. And a lot of times it's hard to get a screening Doppler or an ultrasound because they don't have a family history. But the reality is, it's not so much family history, it's 20% incidence in smokers with cardiovascular factors. So, things that should be considered. Let me point out a couple of fun facts with women. And I think what's interesting about looking as women vascular surgeons at women is you're going to realize the care needs to be customized a little bit more than what we currently offer as a cookie cutter analysis. If you look at women aneurysms, and this was not only a US study, but a Canadian and a Finnish study, they found that women will actually rupture 4 to 5 times at a faster rate in an aneurysm less than 5.5 centimeters, right? So we can't definitely use the same parameters as we do in men because the rupture rate is higher. And then anyone who's been in practice for 10 years or longer and you followed your female patients and some men patients, you will see that they run along a same axis together and then right around 40, 41, 42 millimeters, 4 centimeters, they do jump up. So there's a spike up in the rate of growth for female aneurysms. So again, something to think about. I mean, just following your AAAs, annually like we normally do, I think is something you've got to watch the size, and then at a certain size, I think your surveillance has to be better. Now, we don't see this in our IDE trials, right? When we look at our IDE trials, we see that women are basically underrepresented, and they're anywhere between 9 and mostly 12 or 13%. The outlier there is Airfix IDE trial, which had 29% women. But women don't make it to trials for the most part. And why is it that they don't make it to trials? They don't make it to trials for two reasons. One is either their iliac diameter is off IFU, so it's 6 millimeters or less, and so it doesn't make it to IFU, or their aortic neck, which tends to be shorter and angulated. So their short, fat, and angulated necks do not reach the criteria. So this is another study that looked at about 1,000 patients. Only 12% of women met both iliac and neck IFU requirements. So that's why in IDE trials, we don't see this outcomes of how women do. Now, across the board, if you look at different studies of actually how women do, one thing that points out is they have far more iliac artery injuries. So think about it. You've got a small iliac artery, external iliac artery, common iliac artery. There's tortuosity, there's calcification, because a lot of these women are older. Think about your older female patients. They are prone to having more iliac artery injury because the size of the sheath and the size of the graft invariably is larger because you don't have a lot of those small sizes. So there's more iliac injury, there's more iliac angioplasty and interventions than performed, and a lot of aortouni iliac conversions, iliac chimneys, etc. So the mortality, which is now corresponding to iliac injury, remember, think about an iliac injury you had on the table, more blood loss, usually hypotensive for a while, ends up going to the ICU. plus they're older with the comorbidities. If you look at women and men after EVAR, women are in the red, as you can see. Across the board, they tend to do worse. So think about it from the lens of when you're taking care of these patients. If there's something predictive going on here, there's a difference between men and women aneurysms post-procedure. So NISQIP did a study. They looked at 21,000 patients that were studied with, who were treated with EVAR, excuse me, and chronic renal insufficiency, ASA class, CHF were not predictors necessarily of increased length of stay, but female gender was. So as women, when we're taking care of women, that's something I think we need to consider is that, yes, women are a little bit more complicated and they require a little bit more customized, nuanced care. This was seen in the UK analysis as well. So they looked at 20,000 patients who were treated in 2006 to 2015. And again, you're going to see that same recurring theme, higher readmission rate, longer stay, higher mortality, right? So something definitely there's going on with women, older, complicated aneurysms that don't do as well. So Endologics has had a graft called Ovation, which turned into Ovation IX, and now is called Alto. Alto's been around for the last 5 years. Ovation's been around for about 10 years now. And their initial claim to fame was it was the lowest profile device available, right? 13 French, 12 French, 14 French, you could do it. And that's kind of how we started doing it at GDI and we started adopting it. But since then, two interesting things have happened with Alto. And I don't know how many people are actually familiar with the Alto graft, so I'll simplify it a little bit. The first thing is the neck has a broader neck indication than any other device out there. So the neck only has to be about 7 millimeters. Once you decide on the neck size, you put in the polymer in a liquid form so that it has this custom adaptive sealing ring, which I'll talk about in a second. And then, like I said, it has the lowest profile right now, conformable sheet, and then the stent graft would go through. So this adaptive seal technology allows us to treat angulated, tortuous, bigger necks. And as you know, the neck is the whole deal of the aneurysm, right? First, you got to get access, and then you got to seal the neck. But I think it performs pretty well in these complicated aneurysms. So the very first thing you do in an allograft is you separate out fixation from seal. So think about the other self-expanding grafts that you use. Every other self-expanding graft you use, Medtronic, Gore, Cook, doesn't matter. The concept is the same. You oversize it by between 10 and 20%, and you're hoping that by oversizing it with that outward expansive force on the neck, you're going to fix and seal. So it's kind of not fair. You're taking a graft and you want it to fix and seal in that location that's already in a tortuous neck or a complicated neck, short or angulated. This graph just takes that out of the equation. So first you figure out where it is that you're going to fix it. So you determine that by the CT scan, you do your intraop angio. I'll show you a case example as well. So you fix first. So that mid crown and that suprarenal crown, that's its only job. You find a spot where you're going to go in for renal and you fix it first. So the unsupported main body underneath then can take the curve of an angulated neck, and it is on IFU up to 60% angulated neck. So that's kind of where this graft has a lot of other IFU options that allows you to treat a difficult neck. Once you've done that, now you're sealing with this liquid polymer. So the polymer then goes in kind of where that arrow is on the graft. And think about all the aneurysms you look at. There's calcium, there's thrombus, there's invagination. All of that then goes in a liquid form. And over the next 20, 25, 30 minutes, it forms like plastic into a hard mold. So think of the plastic manufacturing steps. Goes in liquid into a mold and then it turns into a solid mold. That's what you're doing in the body. So at that point, it's really a custom adaptive sealing to that specific neck. And I think that's why the neck remains stable almost 5, 6, 7 years out, and I'll present that data to you as well. So I think this adaptive sealing technology is really what allows good long-term success in this graft as well. So the sheets then are the lowest profile, like I said. I love my Gore graft, I love my Gore limbs, and I love my Gore sheet. But I'll tell you, this is comparable. This is definitely comparable to a Gore sheet and a Gore limb. It definitely allows for the tortuosity. It also has a crossover lumen. A lot of people get concerned about how am I gonna, I've got a timer going, I've got the polymer going, I've got to cannulate the other limb. You can just snare the limb and bring it out on the other side. And then when you put it into a tortuous iliacs, I'm going to tell you it does pretty well. I would say it's comparable outcomes wise of long-term external iliac, common iliac artery. There's not a lot of graft going down or secondary interventions that you have to do for the iliac limbs itself. So how do we know that all of this is true, right? What's the proof? So I'll tell you, there's been one female versus male trial only that was prospective, and that was Lucy. It was only a 1 year trial, but it was more an efficacy trial to see can this be done comparatively in men versus women. It was a 2:1 ratio. We participated at GBI with the Lucy trial, but the data I'm about to show you is actually an encore registry, which is a combination of IDE trials and registry, so prospective, retrospective, and registry, to look at specifically how women did. And the reason I bring this up is because when you look at other trials, and if you put them together, first of all, there really hasn't been a meta analysis looking specifically at women, but women do not do well compared to men when you're looking at freedom from intervention, when you're looking at mortality, for some of the reasons that I talked about. So if you look at the encore study design, it goes across multiple, obviously, studies. So 1,296 patients globally, 160 centers, with a follow-up of 5 years, right? So not just like a 1 year, but 5 year follow-up to see how these patients have done. The sub-analysis showed about 19% women. So it's the first study that includes that many women because more women qualified on their IFU, again, for the reasons that I've shared with you. So if you look at the demographics, there's really not a big difference between the men and the women. It's not like the women were sicker or the men were sicker. The demographics show it's pretty similar, but you do find a significant difference between the men and female, or the women and men aneurysms in terms of things we talked about. The aortic size index, the aortic angulation was worse, the neck length was worse, the external iliac artery diameter was worse. So we know inherently women had worse anatomic characteristics than men did. So if you look at all the reds are the women, the blue are the men, you can see in almost every category that would be considered a hostile neck or a challenging neck, women have higher percentages in this encore registry. And then for the first time, we actually see with this ovation or altograft, women had the same outcomes as men. So this is not something that has been seen before. Women had the same outcomes as men. You could argue we also became, as you do more and more of these cases, you be a little bit more careful about the kind of graft you're selecting, how you're treating the iliac. There's also a learning curve to it, but no question, freedom from all-cause mortality, freedom from AAA-related intervention, and then type 1A endoleak, which is the number one cause of patients not doing well after the treatment, or there's not enough durability in the AAA space because of this. So this is the first time from this, in this large number of patients, women did really, really well. So they were older, they were more complex in that they had more tortuosity, shorter necks, smaller iliacs, and the outcomes were similar in men and women. So I'm going to highlight a couple of different things I think this graft, we think, in my 10 years of experience, is what's going on. So aortic neck dilatation, let's talk about that a little bit. So aortic neck dilatation has been studied fairly significantly now that we have 10 and 20-year data. Post EVAR, what happens? So if you take a self-expanding stent graft, which is mostly available on the market, and you put it in an aortic neck, we're theorizing something happens over time because we're seeing aortic neck dilatation. We're seeing aortic neck dilatation anywhere, depending on studies, from 5% to almost 25-30%. It's not understood why it happens. We think it happens in open aortic repairs as well, but not as much as post EVAR. And when an aortic neck dilatation happens, we don't know whether it's just ongoing degeneration. Is it the outward pressure of the self-expanding stent? Is it outward pressure of the blood pressure? Like, what is it? Nobody really understands the pathogenesis of it. But when it happens, there are more type 1A endoleaks, more migration, definitely more secondary intervention because it's related to a delayed sac growth, delayed rupture, etc. So aortic neck dilatation is definitely a problem that we really don't talk about. Like, think about our surveillance that we do in our CAT scans. We're looking at the sac size, we're looking at the iliacs, we're looking for a 1A or a 1B endoleak, but we're really not following the step before the endoleak, which is, did the neck dilate? Is the graft moving? what's happening. And often it's a cross-center referral, like you come in, you're on call, it's a rupture, and it was done somewhere else. You really haven't had the ability to follow these patients. But when you start looking at your own patients, start thinking about aortic neck dilatation in your CAT scans. We're actually looking at our series for the last 5 years about that. But when you look at 5-year outcomes of specifically type 1A endoleaks and migration, there's a difference in the encore outcomes versus other graft outcomes. And so the question becomes, is it possible, and we don't know, it's a theorizing, that the polymer insulates the neck somehow or protects the neck and there's less outward pressure? And plus, remember, the sealing and the fixation is done by two different parts. There's less migration. So is that a good combination that allows us to have more durable results compared to others? And obviously, better studies need to be done, and this needs to be looked at better. So I'll give you the latest that I found. This is a multi-center retrospective study that looked only at aortic neck dilatation. It's a Japanese study. 111 patients in the alto arm, 111 patients in the other arm, which is basically Cook, Medtronic, Terumo. And they looked specifically at 12 months, what they call proximal neck dilatation. They found 2.3% proximal neck dilatation versus 26.7 in the non-alto group. They also found a risk of 2.9 times higher of having a type 1A endoleak in the other arm compared to the alto arm, and migration was 6 times higher, 5.95 times higher in the non-alto arm. So it's a multi-center. Yes, it's a Japanese study. It's 111. We haven't necessarily looked at it like that here in the U.S., but I think it's worth paying attention to. That this is something that potentially can happen to our patients, and long-term follow-up on all of our EVARs, specifically, I think, with aortic neck dilatation becomes important. So I'll bring you back to how I started with Alto almost 10 years ago. And in my practice, a lot of women were coming to me. I was about 10 years in practice at that point. And I think that's how the trajectory goes. As you start doing more and more, you're in practice between 7 and 10 years, your aortic volume starts to pick up. And interestingly, especially nowadays, I feel a lot of family will do their research and they will seek out women to treat women. Women feel very comfortable with women. So I wanted to be able to offer percutaneous interventions at that time. I was looking for lower profile devices that I could use it. But sure enough, if you attract more women and certainly some men, it came with the hostile or challenging neck, short necks, more calcium, more thrombus. And so that's how I started using this graft more like a niche graft in those cases. And as time has gone on, what I found was this graft tends to perform pretty well. So we are now involved in looking at our 5-year experience to look at specifically the Alto graft, which became available in 2020. We participated with the Elevate trial, which was the IDE trial for Alto. And I'll tell you a couple of things that are different about this graft, that you don't have to worry about in a different graft, is you need to measure it appropriately. So we'll go through a case and I'll go through the measurements with you, but that's what becomes different about this graft. And in fact, the fellow at that time, Dr. Khan, is now Dr. Harris's partner. He helped me with our first Alto implant. And in 5 years, we found pretty good initial and long-term results, which echo what Encore showed. So what I'm trying to explain is the real world results, I think, are pretty good, even as as you start to take on these. So I'll give you an example. This is our typical 86-year-old, didn't really take care of herself, had was known to have a aortic aneurysm like 2 or 3 years ago when she had a previous CT scan, came in for kidney stones, which is a fairly common reason for these patients to get a CAT scan, and then sure enough, now it has grown to 5 centimeters. So look at the calcification of the iliacs, a little bit of tortuosity, about a 60-degree angle right around the neck, and you can see it's that challenging neck because it's a pretty tight distal aorta. So if you look at the iliacs are borderline, just around 6-7 millimeters. If you look at where the suprarenal part is going to go, the crown is going to go, you have to measure that. That's different from what you would do in a self-expanding stent graft. And then you have to spend a little bit of time looking at where you're going to let those sealing rings sit, which is usually going to be between 7 and 10 millimeters infrarenal, which again is different from the other grafts. You look at the distal aorta. The distal aorta was small, which can be challenging in other grafts. And then you look at how the calcium is in the iliacs, how much tortuosity there is. And as you can see, this woman had pretty good tortuous calcific vessels. So this is where our P2 plus 10 was. So this is where you would put the ceiling ring. The bottom of the ceiling ring would probably go there. The top of the ceiling ring would probably be closer to P7. You have a little bit of wiggle room to go between 7 and 10, but if you're looking for a really good seal, usually the higher, it's a little bit better. This is the case plan that you would do. So I typically like to look at the CT scan. I like to think about which graft I'm going to go with. If I choose I'm going to go with an allograft, which is more than I do with the other grafts, then I actually sit down with the rep, size myself, have them size it, make sure we have a few different sizes available so that we can do this. Now the graft is put in as a modular graft. So you would basically do your aortogram, you would look at your renals, you would place your suprarenal crown, like I said, fixed first, just below the renals, and then you would have the two pant legs come in. You'd cannulate both limbs, one limb at a time. But just before you do that, you would seal. So you fix first, then you seal, then you cannulate. Check your hypos, and then you would put the legs in. And that's what that completed a scan looks like. So this woman is now 4 years out, and so far, no problems. Follow up CT scans look pretty good. So the real world evidence across the board seems to be similar to what the Encore registry showed, which is of those 6 studies, 1,296 patients, patients were older, more complicated, and definitely did as well as men did. So I'll leave you with a couple of thoughts. One is thank you for the invitation to be here, and congratulations, Linda, and the other organizers on really another successful meeting. It was so good to see a lot of you having fun last night. I felt a little underdressed, so I ran away. But it's really it's grown to be a great organization. It's got a very very nice network feel to it. I love that younger women have a place to come to and to talk about it, which we certainly didn't have. So really, thank you, Linda, for getting it all together. It's a labor of love to get a meeting together and to keep it running, and certainly to keep it growing.